once again. Welcome to Grumpy Science with Mark Tommerdahl and Bob Dennis. And today we're going to talk about the extremely pleasant and entertaining topic of
pain
and the opioid crisis.
And not just the kind of pain we bring you whenever you watch one of these videos.
Right, the kind of pain that doesn't go away even when you fast forward or change to a Grumpy Cats video.
That's right.
No
hey,
treatment.
I just actually typed in Grumpy Science.
And?
We're actually coming up pretty high up on the
We're
list.
right below the most popular Grumpy Cat videos. So maybe we'll be a little bit less grumpy when we're more popular than
Nah, I don't think so. Still going to be grumpy.
Don't bet on it. I'm just wishful thinking.
So most people, especially our learned listener, should I say listener or listeners?
I don't know if both are going to watch this one, but go ahead.
Okay. Well, I think both of them probably know about opiate crisis and how, that's causing a real problem with the pain, and that's
so we had a doctoral
$500
student do a proposal.
Yeah, he did his dissertation proposal, did a very good job, and we
had a committee meeting on it. It's very interesting. We both have an interest in it. Mark has studied pain for how many decades?
About 30,
about
30 years.
3 years.
Yeah.
And I'm a sufferer of chronic pain, which is not fun for the many hundreds of millions of people who do that. And so opioid crisis, right? Well, one of the things I asked our student was, how big in dollars, total dollars, is the opioid, the chronic pain crisis actually? What does it cost the U.S. economy?
Something like $500 billion per year.
Best estimate is actually a little bit more. It's something like $680 billion, closer to two-thirds of $1 trillion every year in the U.S. economy, where our GDP is something between 18 and 20 trillion. So it's about 3% of the U.S. economy is lost to chronic pain, and that's about the size of the defense budget. It's about 10% more than the entire defense budget. And last time I heard a congressional debate on whether or not we should keep chronic pain or maybe boost it to help the economy. I can't remember the last time it was even discussed in the context of being probably the single most costly thing to the United States.
Yeah, it's actually a very tiny study section.
Yeah, well,
relative to the rest.
At the NIH, it's a tiny study section. I don't know that the United States Congress, has ever even thought about the issue, addressed it specifically. Right. Other than when it came up as the opioid crisis, which Mark wants to talk. We'll be looking over at some data here and then sort of talking you through data.
Oh, actually, I thought we were just going to pretend we knew this off the top of our head.
Heck no, I don't know anything. I got to write my name down on a piece of paper. So I can remember. Hi, this is Bob Dennis.
Yeah.
Right. So anyway, our student showed interesting data. How would you summarize the data on the opioid crisis from 2000 to 2015?
Looks like it's going up.
It's going up sharply, and it looks to me like people are starting with natural and semi-synthetic opioids, and then when they can't get them, they move on to the next best thing, which is heroin,
and then synthetics,
and then they go, if they can get the synthetics, they go to them. So that's what people do.
A lot of this starts with prescription, and just
that seems to be the case. That seems
a lot of this is from pain that people just can't deal with, which hopefully our two viewers don't have.
Right. Well, the interesting thing is there are actually studies now showing, and this was my experience, was that opioids don't really reduce pain that much. That's the interesting thing. What they do is they seem to. It's hard for me to explain. I feel like I'm in just as much pain. I just don't care as much. Right? And I don't bother other people as much. And so I suppose that reduces their pain. They don't have to hear about my pain. It's hurting me.
You're faking it. You look
faking
fine.
it. Yeah, that's right. Go show me your pain. Well, I can't. Right? You can't. It's one of those weird things about pain, right? You can measure blood pressure. You can measure somebody's height and weight, and you measure their cholesterol and stuff like that. You measure their, sugar in their blood, but you can't.
It was actually one of the reasons we got started with the brain gauge, because we wanted to come up with a way to measure pain. And so this sort of segues into where does pain come from?
Yeah.
Well, it's don't want to get the wrong idea, but if I say it's all in your head, it is in your brain.
It's your brain's interpretation of signals.
And even though, let's say you crush your hand, there's a place in your brain that's telling you it hurts.
Right. We're not saying it's not real. We're just saying
that
pain is one of the many illusions that your brain gives you to tell you about important things in your environment. And sometimes sometimes that pain isn't really related to a real injury. Sometimes your brain gets kind of locked into these responses that make you experience pain. Like a great example is phantom limb pain, right?
Right.
How can you have a hand that hurts if that hand is gone?
Right.
That pain is just not helping you in any way, right? It's just hurting you.
So we did a number of studies on this. We actually called it maladaptation. But one thing a lot of people don't really think about is that when you think about the different sensory systems, there's actually 5 or 6 of them, depending on how you count them. But the 3 that most people automatically jump to are vision and auditory, that's hearing, or somatosensation, sense of touch. And they think, oh yeah, whatever. And they don't really think about pain being involved in any of those. And actually, they're not involved in all 3. They're only involved in 1.
We've discussed this before. Pain is adjacent to and in some ways complexed with the somatosensory system.
Yep.
And each side of your brain. And that somatosensory system is the system that you use to feel things, right?
So you actually have pain receptors in all parts of your skin, and they project up into a place in your brain that tracks right next door to the place that receives mechanical inputs.
Right.
And mechanical inputs are what determine how well you do on your brain gauge scores. And a lot of those scores are really impacted significantly when you have pain.
Well, things cross over in the brain sometimes. You'll get a sensation for a limb that's not there. People will see sounds as colors, perceive colors as numbers as colors.
Well, that's synesthesia.
And I think synesthesia is distantly related to this because it's in a different part of the brain.
Not really.
Not really. Okay, so I'm wrong.
Yeah.
I thought it had something to do with crossing signals in different functions of the brain. Maybe I'm wrong.
Synesthesia is probably another video, but that's a good
topic. Let's not get into it. But the point is that sometimes your brain gets a signal and interprets it wrong. In the case of pain, that's actually spatially correlated with normal sensations of feeling, tactile feeling.
Yeah, and so we did a bunch of experiments looking at relationship between your perceptive of mechanical stimulus, like what you feel on the brain gauge, versus level of pain. So of course we were doing experiments on ourselves where we delivered things that didn't feel so good, and while we were doing a test, and we actually came up with some ways to reduce that during the thing. But thing we wanted to talk about today is that people may not realize this, but there are actually some surgeries that were done in the 1940s and 50s that were very successful.
Well, it was even before that, and I didn't know this, but our student taught me this anyway. Was that in the 1880s? So this is like 140 years ago. They actually mapped how different lesions in the somatosensory cortex could have an analgesic effect. And that's what he's got on the slide here. Dana mapped lesions causing analgesia in 1888, right?
Yep.
So what they're saying is probably if they took like a probe tip, opened up your, access to your brain, pulled back the derm and start causing lesions with a metal object in your brain, that you lose the pain in certain areas.
Right. Then a couple of Germans, one from World War I, one post World War II.
Right.
They did the same thing. They looked at where bullet lesions had caused people to lose all sense of pain, and there was in this one area in somatosensory cortex.
Right.
And so people thought, hey, maybe that's a way to.
So the idea was you want to block pain. Right? You find that point in the brain that corresponds to the pain that you're feeling. And they did that a few kind of clever ways by stimulating that point. Whoa, I'm feeling more pain. In this exactly the same spot? Yeah, so if you cause a lesion there, so that doesn't work anymore, then maybe you won't feel any pain anymore. And that was successful like 60, 70% of the time in some cases.
Yeah, like 70% of the time. And there was a lot. And this was actually getting steamrolling. I mean, keep in mind the surgery was they'd open up your skull and then they'd map it from verbal feedback. Right. You touch a place in the brain. I don't know if people know this, but your brain itself doesn't have any nerves. So you cut off that skull and you don't feel anything, but then you start poking around
in somebody's brain, and they'll be like, "Whoa, somebody's touching my foot."
That's right. You touch my foot, touching my hand. That's the way they map it during surgery. Is they actually ask you for feedback. Well, these surgeons were doing that. and then they remove
finding the point
that one
that
place in
corresponded
cortex.
with the pain that the person was feeling, and then they would actually with a scalpel, right,
Just
remove
scoop it out and then say, okay, how's your
that part of the
pain?
brain's gone, and then people would be like, actually, you know, it was. I think the answer was that for a large percentage, it was at least 2/3 of people. They're like, well, the pain's gone, or it was so reduced they could manage it with aspirin or something like that, and that's pretty amazing, right? So, so this is the story of science killed by a bad paper in 1969.
One paper in 1969
by Sweet and White.
I guess
to me sounds like a description of powdered sugar, but.
Yeah.
Okay. So they wrote a paper where they more or less ignored a lot of data. They did some experiments the wrong way. They did it the wrong way, and then they said, well, if the pain isn't completely gone and you still need aspirin, then that's counted as a failure. And then they miscounted some stuff. And when you added up all their mistakes, they said, well, that surgery doesn't work.
Yeah, like one of their measures of success was whether or not the patient would fill out the survey. And some patients just didn't want to bother with it. I mean, some of the former patients from the others.
Any lapse of information was taken as a failure rather than non-data.
So they set out to make sure it looked like it failed.
Right.
But then Bob, do you know what they suggested to do instead?
Yes, I do. No. Don't take out this little piece of the brain that specifically corresponds to a point on your body that's causing pain. Oh, no, they had a much better general solution. Which is?
Frontal lobotomy.
There you go. So this is 1969, right? Anybody who's seen, One Flew Over the Cuckoo's Nest, things like that. This is not cool, right? But these guys actually said, so there's all this, there's a large and growing body of scientific evidence that worked pretty well for a lot of people. It was used pretty widely, and then it was stigmatized by one pair of guys who were saying, no, doesn't work. Just do a frontal lobotomy, which they can do,
Then they won't complain any.
Then they won't complain. So then the question, he never answered the question is, are the people still feeling pain but simply unable to express it? Are they not, bothering their caregivers anymore? Maybe that means the pain's gone.
Just sedate them, and then that'll take care of the whole problem.
Absolutely. So frontal lobotomies for pain. I would say, does that get the grumpy scientist seal of approval?
No.
That gets a 2 thumbs down.
I would say down.
No scientific basis. Bad science to defame. First of all, I wouldn't do the surgery myself. There are people with intractable pain. That should be an option.
By the way, these guys were prominent neurosurgeons, so everybody said, "Oh, okay." They didn't do the frontal lobotomies, but they quit doing.
As soon as these guys poo-pooed it, they were kind of like, everybody was kind of like afraid to be stigmatized by, doing something that had been disparaged by the people at the top. So you see this a lot in medicine. You still see this today. If the top opinion leader says something doesn't work, or that's quackery, right? That's what they say today. People run away from it. Nobody wants to have the the dark stain of quackery on them. But there's a case that was real science. It was really quashed by a couple of people who did bad science and had a biased opinion. That was clearly wrong.
Yeah, that's right.
So anyway, I think that's probably enough on that topic. I think that's it. Anything else?
Nice short video.
Thanks for joining us. We'll see you later.